Usually when we talk about a medical diagnosis, there is this expectation of absolute precision. Like it feels like engineering, right? You fall off a bike, you break your arm, the x-ray shows that jagged white line, and the doctor just points and says, yep, there it is. That's the problem.
Yeah, it's comforting. It is very binary. I mean, the bone is broken or it isn't. You cast it, it heals, and you move on.
Exactly. We like our medicine to be visible and neatly categorized. But then you step into the world of neurology, specifically the electrical storms of the human brain, and suddenly that x-ray machine feels completely useless. Like if you are a patient navigating an epilepsy diagnosis, you are stepping into a landscape that is honestly incredibly murky.
Oh, absolutely. It is the absolute definition of diagnostic muddy waters. And, the tools we use to navigate those waters, the medications themselves, they're just as complex and, well, historically misunderstood.
Right. Which brings us to our mission for today. So welcome to today's deep dive. We're thrilled you could join us because we are plunging into the pharmacological world of antiepileptic drugs, or AEDs.
Which is a fascinating topic.
It really is. We are going to explore how they attempt to control those electrical storms in your brain, the utterly bizarre and accidental history of how they were discovered, and the core mechanisms they use to calm the neurological firing.
And maybe most importantly, we're going to reveal why the very name of this drug class is actually a massive medical misconception.
Okay, let's unpack this. And I think we need to start with a pretty massive bombshell from the source material. Antiepileptic drugs do not actually cure epilepsy?
They don't. And this is a foundational misunderstanding, not just among the general public, but historically within medicine itself.
Wait, really? Even doctors misunderstood this.
Oh, for a long time, yeah. To understand why we are still battling this misconception today, you have to separate two distinct pharmacological concepts. So you have a drug being symptomatic versus a drug being anti-epileptogenic.
Okay, those are heavy terms. If I am a patient taking a daily pill, what is the actual difference between those two?
Right, so symptomatic means the drug just treats the symptom. In the case of these drugs, it raises your seizure threshold, making a seizure less likely to happen, or it just interrupts the abnormal electrical firing once it begins.
Okay, that makes sense. And the other one?
But anti-epileptogenic means a drug actually stops the underlying disease process of epilepsy from developing in someone at risk. Or, it reverses the tendency to seize once that condition exists.
Right.
And here is the sobering reality. Every single approved agent in this entire class of medications is merely symptomatic. I mean, none of them have been proven in humans to be anti-epileptogenic.
Wait, so taking an AED is basically like taking a really strong painkiller for that broken arm we just talked about.
Essentially, yes.
Like, it masks the symptom entirely, you feel totally fine, but when the drug wears off, the bone is still physically broken?
That is a perfect analogy, actually. If a patient takes an AED and is completely seizure-free for 10 years, I mean, that is a massive clinical success.
Sure, the drug did its job.
Exactly. But if they taper off and stop taking that drug, very often the seizures return immediately. The drug was managing the symptom beautifully, but the underlying epilepsy, the broken bone in your analogy, was still sitting there the entire time.
The disease itself wasn't reversed or cured.
Right, it was not.
But we literally call them anti-epileptic drugs. That implies they are fighting epilepsy when in reality they just fight the seizure. Why did the medical community adopt such a misleading name?
Well, you have to look back to the 19th century for that. There was this brilliant neurologist named John Hewlings Jackson. He was one of the first to really conceptualize what a seizure actually was.
Oh, okay. What did he say?
He defined it as an occasional, an excessive, and a disorderly discharge of nerve tissue.
So he was defining the event itself,
Yeah.
like just the electrical discharge.
Precisely. And for over a century, the event was the only thing doctors could actually observe and attempt to treat.
Just stopping the visible shaking or staring.
Yeah. The underlying condition, like epilepsy itself, remained this clinically fuzzy, vague umbrella term.
It seems wild that a major medical field could operate for over 100 years without a strict definition for the disease they were treating.
It is wild. And honestly, it wasn't until 2014 that the International League Against Epilepsy, the IAE, finally issued a strict operational definition for the disease.
Wow, 2014, that is incredibly recent.
It really is. The ILE, led by Robert Fisher, drew a hard line in the sand. They established that you diagnose someone with epilepsy only after 2 unprovoked seizures occurring more than 24 hours apart.
Or 1 unprovoked seizure with a demonstrably high recurrence risk.
Right, exactly.
Why does that 24-hour gap matter so much, though?
Because if you have multiple seizures within a few hours, it's often viewed as a single continuous neurological event. or, a reaction to an acute trigger, like a really high fever or severe dehydration.
So it's a reaction, not a chronic condition.
Right. But if you have a seizure, you fully recover, wait a day or more, and then your brain spontaneously generates another one, well, that proves your brain has developed an enduring underlying predisposition to seize.
And that enduring predisposition is the disease of epilepsy.
Exactly.
And because these drugs don't fix that enduring predisposition, they just stop the visible event, we probably shouldn't be calling them anti-epileptic drugs at all.
And that is exactly what the ILA is saying now. Because of this reality, there is a massive push right now to change the entire medical vocabulary.
Oh, really? What are they changing it to?
They want clinicians and patients to drop the term AEDs and start calling them ASMs, which stands for anti-seizure medications.
Anti-seizure medications, ASM. Okay, that makes total sense. It's way more accurate.
It is a much more honest reflection of what the chemistry is actually accomplishing in your brain.
But this raises a huge logical problem for me. If these early doctors were only ever treating a symptom, and they had absolutely no idea what the underlying disease even was, how did they figure out what pills to give people?
That is the crazy part.
Or were they just throwing random chemicals at the wall to see what stuck?
Basically, yeah, they were completely stumbling in the dark. The history of this field is essentially a series of incredibly lucky and sometimes completely absurd accidents.
See, this is my favorite kind of medical history.
Yeah.
You have a patient seizing, you have a cabinet full of random 19th century powders. What happens?
Well, let's jump to 1857. Sir Charles Locock was a British physician, and he became the first person to demonstrate that a chemical compound could reliably control seizures.
Okay, what did he use?
He used potassium bromide to calm seizures in women, but, and this is the kicker, his reasoning for doing so was entirely spectacularly wrong.
Wait, if his logic was wrong, why did he pick potassium bromide out of everything else he could have tried?
He was working from this wild, prevalent theory of the era that linked epilepsy to menstruation, and he firmly believed the seizures were triggered by excessive sexual excitement.
Oh my goodness, that is definitely 1800s medicine for you.
Right, and bromide was already known at the time to have a highly sedating, libido-dampening effect.
I see where this is going.
Yeah, so his medical logic was basically, I will give my patients bromide, it will dampen their libido, and therefore the seizures will stop.
So he thought he was treating sexual excitement, which had absolutely nothing to do with the epilepsy.
Yeah.
The patient took it, and the seizures actually stopped.
The seizure suppression was very real. I mean, the bromide genuinely worked to quiet the brain.
That is just wild luck.
And because it was the only thing that worked, bromides became the gold standard treatment for epilepsy for the next 60 years.
That is terrifying, considering how toxic bromides are. Like, if you took them daily for years, you develop bromism, right?
Yes, severe bromism.
Which means severe sedation, skin eruptions all over your body, even drug-induced psychosis. Patients were just enduring brutal side effects for 6 decades.
It was awful.
How did we finally pivot away from that?
Well, in 1912, we get another profound accident, courtesy of a German psychiatrist named Alfred Hauptmann.
Okay, what did he stumble into?
He ran a shared hospital ward full of patients with epilepsy, and they were having frequent seizures at night, which meant nobody in the ward was sleeping. Not the patients, and definitely not the exhausted hospital staff.
So this wasn't even a grand scientific experiment. He just wanted some peace and quiet for his staff.
That's entirely it. He administered a drug called phenobarbital to his patients strictly as a sedative, literally just to knock everyone out so the ward could get a good night's sleep.
Just a heavy sleeping pill.
Exactly. But the next morning, and in the days following, he noticed something remarkable. The frequency of their daytime and nighttime seizures dropped dramatically.
Wow. So he accidentally discovered the first rationally adopted alternative to toxic bromides just by acting as an exhausted ward manager.
Yep.
But wait, is a seizure just an awakened brain firing too much? Like, can you literally just put the brain to sleep to stop it?
Well, sedation and seizure control overlap, but they aren't the exact same biological mechanism.
Oh.
Hauptmann just stumbled into a drug that happens to do both. And phenomenally, phenobarbital is still around today.
Really? 100 years later?
Yeah, it remains the most widely used anti-seizure drug globally, largely because it is incredibly cheap to manufacture, so it's a massive lifeline in low-resource settings.
That makes sense.
But back in 1912, it cemented this false idea that anti-seizure and heavy sedative were the exact same thing.
We can't just leave patients heavily sedated for their entire lives, though.
Yeah.
We had to figure out how to decouple the seizure control from the sleepiness.
Right, and that vital paradigm shift finally happens in 1937 and 1938 with two researchers named Tracy Putnam and Houston Merritt at Boston City Hospital.
Okay, how did they figure it out?
They decided to stop waiting for clinical accidents. They developed an animal model, specifically a cat electroshock model.
Oh, wow.
Yeah, they applied an electrical shock to a cat to mimic a seizure, and then systematically tested different chemical compounds to see what would stop it.
But the genius here is what they were measuring, right? Like, they weren't looking for a better sleeping pill.
Precisely. They deliberately screened for compounds that elevated the seizure threshold without putting the cat to sleep.
Which proved, once and for all, that you could separate seizure control from general sedation.
Exactly. And through this rigorous screening, they discovered phenytoin, also known as Dilantin, which is still a frontline medication today.
So they basically wrote the modern playbook, used targeted animal models, not accidental human sedation.
Yeah, they really did.
Here's where it gets really interesting, though. You'd think after Putnam and Merritt, everything in this field became perfectly calculated, rigorous science.
You would think so.
But then you look at Pierre Aymard in 1962, and it might be the wildest accident of them all.
Oh, the valproic acid story. It is legendary in pharmacology.
Tell me about it.
Aymard was a French researcher working in a lab that was screening dozens of new candidate compounds for anti-seizure activity using that exact same animal model approach Putnam and Merritt pioneered.
Right. And if you're a chemist, testing all these new solid compounds, you can't just feed a dry powder to an animal. You have to dissolve it in a liquid, a solvent, so you could administer it consistently.
Yes. And Aymard chose valproic acid merely as his organic solvent. As far as he was concerned, it was completely biologically inert.
It was just the liquid holding the drug.
Exactly. It was just the delivery vehicle, the mixing bowl to carry the actual experimental drugs he was trying to test.
So he injects his first experimental drug, and the seizures stop. He injects the second experimental drug, and the seizures stop. It looks like every single drug he's inventing is a miracle cure.
It must have felt like he was a genius, right? Until he finally realizes that it wasn't the experimental drugs doing the work at all.
It was the solvent itself.
Yes. The supposedly inert liquid vehicle was actually one of the most potent anti-seizure medications ever discovered.
That is incredible.
Valproic acid became a phenomenal broad-spectrum drug, found purely because it was being used as a mixing bowl.
That is just mind-blowing. But, all of these stories, Locock, Hauptmann, Eimert, they highlight a really big transition in medicine.
How so?
Well, finding these drugs empirically, whether by sheer luck or by shocking cats, was a great start. But eventually, neuroscience had to catch up. Like, when we finally started looking under the hood at the brain circuitry, what were these accidental drugs actually doing?
Getting into the mechanisms.
Yeah. If we think of the brain's neural network as a high-performance car engine, are these drugs yanking the emergency brake or just taking the foot off the gas?
Depending on the specific drug, they actually do both.
Oh, really?
Yeah. Fundamentally, a seizure is a massive problem of neuronal excitability. It's a synchronized runaway wave of either too much excitation or too little inhibition.
Okay, so it's a balance issue.
Exactly. Every single anti-seizure drug works by attempting to tilt that delicate balance back to normal. So let's look at the first primary strategy, which is taking the foot off the gas.
Okay, dampening the excitatory fire signal. How do we do that?
That primarily happens at the voltage-gated sodium channels. Think of a neuron in your brain like a tiny battery. In order to fire an electrical signal to its neighbor, it has to temporarily open these microscopic gates or channels to let positively charged sodium ions rush inside.
Okay, I'm with you.
Drugs like phenytoin, carbamazepine, and lamotrigine bind directly to these sodium channels. But the truly elegant part is that they preferentially bind to the channel when it is in its inactivated state.
Wait, let me make sure I'm visualizing this correctly. An inactivated state, does that mean the gate is locked?
Basically, yes. When a neuron fires a normal, healthy signal, the channel opens, lets the sodium rush in, and then briefly snaps shut. It inactivates for a tiny fraction of a second before it can reset and fire again.
So it's just a normal part of the cycle.
Right. Normal firing is occasional, so the channel is only closed for brief moments. But during a seizure, the neurons are firing at an abnormally fast runaway frequency.
Ah, I see. Because it's firing so incredibly fast, those channels are spending a much higher percentage of their time in that snapped-shut, inactivated state.
Yes, you've got it. And this creates what we call use-dependent blockade. The harder and faster the neuron tries to fire, the more opportunity the drug has to bind to it and lock it down.
That is brilliant.
It selectively targets and mutes the runaway, high-frequency epileptic firing while barely interacting with the normal, occasional firing of healthy brain activity.
Which is the magic of how you can halt a seizure without just anesthetizing the patient's entire brain.
Exactly.
That is an incredibly elegant biological mechanism. Okay, so that's taking the foot off the gas. What about the other side of the equation? What does slamming the brakes look like?
Slamming the brakes involves a neurotransmitter called GABA. GABA is the brain's primary inhibitory signal. It is literally the chemical brake fluid.
Okay.
If you can enhance GABA, you hyperpolarize the neurons, making them much harder to fire.
And there are two heavy hitters in pharmacology that do this, right? Benzodiazepines, like Valium, and our old friend from the noisy hospital ward, barbiturates.
Yes, exactly.
But they don't apply the brakes in the exact same way, do they? Like, if you take too much of one, the outcome is vastly different.
It is a critical difference. Both classes of drugs bind to the GABA-A receptor. Picture this receptor as a doorway on the neuron that lets inhibitory chloride ions flood inside to cool things down.
Okay, visualizing a doorway.
Benzodiazepines act like a chemical doorstop. They wedge themselves in, keeping the door open longer, but, and this is key, they can only keep the door open if GABA itself is already present to turn the handle.
So they need the natural chemicals there to work.
Right. If the brain runs out of natural GABA, the benzo is useless. It can't force the door open on its own.
It requires a partner. It just enhances what the brain is naturally doing anyway.
Exactly. Barbiturates, on the other hand, act completely differently at high doses.
Oh boy.
They don't need GABA to turn the handle. They can literally kick the door open all by themselves. Yeah, they force that inhibitory chloride channel open directly. And that is exactly why barbiturates are profoundly more dangerous in an overdose.
Because they just take over.
Yes, they can force the brain to shut down completely, suppressing your breathing and heart rate, regardless of what your brain's own natural chemicals are trying to do.
Okay, so kicking the door down is obviously dangerous.
Yeah.
Is there a way to increase that natural brake fluid without physically forcing the receptor open?
There is. Instead of targeting the receptor doorway, drugs like vigabatrin and tiagabine manipulate the supply chain of GABA itself.
Oh, how so?
Vigabatrin permanently blocks the enzyme that normally breaks GABA down. So, without the cleanup crew, the brake fluid just keeps pooling in the synapse.
Oh, clever. And tiagabine.
Tiagabine works by blocking the biological vacuum cleaner that normally clears GABA away. The result is the same: more ambient brake fluid, more constant inhibition.
So we have sodium channels to stop the gas and GABA to hit the brakes. But there's a fascinating exception here in the sources. Not all seizures use those mechanisms.
No, they don't.
What about absent seizures?
This is a crucial distinction. Absent seizures, which are incredibly common in childhood epilepsy, they look entirely different.
Right.
They don't involve thrashing or convulsions. They're these brief, blank, staring spells.
It often just looks like a child is daydreaming in class, right?
Yes, but their brain is actually locked in a seizure.
And they were driven by a completely different engine.
Yes. They are generated by a very specific rhythmic electrical circuit looping between the thalamus and the cortex. And they are driven by T-type calcium channels, not sodium channels.
Oh, calcium channel.
These calcium channels create this highly synchronized 3 per second oscillation.
So if a well-meaning doctor misdiagnoses that staring spell and prescribes a sodium channel blocker like phenytoin, what happens?
It completely fails.
Really?
In fact, giving the wrong mechanism can actually exacerbate certain seizures. To treat absent seizures, you need a drug called ethosuximide, which specifically blocks those T-type calcium channels. And the kicker is, ethosuximide is essentially useless for almost any other type of seizure.
Wow. So this proves the central pillar of modern prescribing. Like, mechanism dictates the treatment.
Yeah.
You aren't just handing out a generic AED. You're actively trying to match a highly specific chemical key to a unique biological lock.
Which sounds incredibly clean and logical on a whiteboard, right?
Yeah.
But then you have a modern blockbuster drug like levetiracetam. It's prescribed everywhere, and it completely ignores everything we just talked about.
Wait, it doesn't use sodium, GABA, or calcium?
Nope. It doesn't touch sodium channels, GABA, or calcium. It binds to a specific synaptic vesicle protein called SV2A, basically modulating how neurotransmitters are released.
That's entirely different.
But the wild part is, levetiracetam was approved and widely prescribed for years before scientists in 2004 finally figured out that SV2A was the target.
Oh my gosh. So the historical pattern of, discover it works first, figure out why later, is still very much alive today.
Still very much alive.
So matching the drug's mechanism to the specific seizure type is the goal. But when you move from the laboratory into a real complex human body, things get messy fast.
They really do.
It becomes this perilous balancing act between efficacy, like does it actually stop the seizure and toxicity? What damage is it doing to the rest of the patient's body?
It is arguably the most difficult aspect of managing epilepsy.
And I want to challenge a really common assumption here. If you are a patient, you probably assume that the newest drug, the one invented in 2020, is inherently safer and more effective than the one invented in 1962.
Right. We assume medical progress is linear.
Exactly.
But what's fascinating here is a massive, incredibly important head-to-head study out of the UK called the SANAD trials.
Okay, what do they do?
For decades, doctors just prescribed whatever they were personally used to. The SANAD trials actually put these drugs in a ring together across thousands of real patients to see which genuinely worked best for long-term seizure control.
Like a massive pharmacological tournament.
Exactly. And the results shocked a lot of modern neurologists.
Because the old cheap drugs won.
They did. For generalized epilepsies, valproate, our old friend, the accidental organic solvent from 1962, it actually outperformed the newer, heavily marketed, much more expensive drugs.
Just in raw seizure control.
Yes, in raw seizure control and keeping patients seizure-free.
But it won at a terrible cost, didn't it?
A truly heartbreaking cost. This brings us to the teratogenicity crisis.
The teratogenicity,
Yeah.
meaning birth defects.
Yes, valproate is undeniably effective at stopping seizures, but it is deeply linked to severe birth defects if a woman takes it during the first trimester of pregnancy.
That's awful.
And even more devastatingly, a landmark trial called the NEAIDS study, led by Kimford Metter, proved that valproate exposure in utero is associated with a measurably lower IQ in children by age 6.
That is just a staggering reality to process. A young woman walks into a neurology clinic, and the doctor essentially has to say, look, I have a drug that will absolutely control your seizures, but if you get pregnant, it could permanently lower your child's IQ.
Yeah.
That isn't just a medical choice. That is an impossible moral calculus.
It is an agonizing reality. It's a dose-dependent effect, meaning higher doses carry higher risks. This forced regulators in Europe and the UK to impose strict pregnancy prevention programs.
So they have to manage this constantly.
Neurologists and female patients of childbearing age are forced into a constant tightrope walk. Do you prescribe the most effective drug and risk catastrophic fetal development?
Whoa.
Or do you prescribe a safer but less effective drug and risk the mother having a massive, potentially fatal seizure while pregnant?
Wow. And sometimes the toxicities aren't just developmental, like they are swift and catastrophic for the patient taking them.
Right, like Thelbamate in 1993.
On paper, that looked like an absolute miracle drug for a severe treatment-resistant childhood epilepsy called Lennox-Gastaut syndrome.
It was heralded as a massive breakthrough. It was approved, rolled out, and within a single year, the FDA had to issue black box warnings and drastically restrict its use.
This was causing aplastic anemia, right?
Yes, where your bone marrow just suddenly stops producing new blood cells. And fulminant liver failure. Several patients died.
It's terrifying.
Today, it survives only as an absolute last resort option, requiring intense, continuous blood monitoring.
Or vigabatrin, the drug we mentioned earlier that boosts GABA.
Yeah.
It is miraculously effective for infantile spasms, which is a devastating pediatric condition that destroys a baby's cognitive development.
But in up to a third of long-term users, vigabatrin causes irreversible peripheral visual field loss.
And irreversible.
Yes. The patient slowly goes blind in their periphery, and once it's gone, you cannot get it back. It's a deliberate, terrifying trade-off. Save the infant's brain, but potentially sacrifice their vision.
Now, if you are listening to this and you don't have epilepsy, you might be wondering why you need to know about the pharmacology of older anti-seizure medications. Like, why does this matter to the general public?
It matters a lot, actually.
And the answer lies in something called hepatic enzyme induction.
This is a critical piece of public health knowledge. Many of the older drugs, specifically phenytoin, carbamazepine, and phenobarbital, they are massive enzyme inducers.
Okay, what does that mean in plain English?
They rev up the cytochrome P450 enzymes in your liver. These are the biological incinerators that clear foreign chemicals out of your bloodstream.
So if you take one of these older ASMs, your liver essentially goes into overdrive.
Exactly. But it's indiscriminate. It doesn't just clear the seizure drug faster. It clears other daily medications you might be taking significantly faster too.
Wow.
The most consequential real-world interaction is with hormonal contraceptives.
Birth control.
Right. If you're taking birth control pills and a doctor puts you on carbamazepine, your hyper-efficient liver chews up the contraceptive hormones so fast that they never reach therapeutic levels.
The birth control simply fails.
Yes.
That is a massive patient safety interaction. Anyone taking these medications needs to be hyper-aware of what else is in their system.
Absolutely.
But hearing all of this, the liver interactions, the vision loss, the severe birth defects, it begs the question, why do patients endure this? Why not just risk the seizure?
Because the alternative is often much, much worse. Poorly controlled recurrent seizures can lead to a phenomenon known as SUDP.
Sudden unexpected death in epilepsy.
Yes. It is the leading cause of epilepsy-related mortality. A seizure isn't just a shaking spell, it's a massive physiological stressor that can shut down respiratory or cardiac function.
So the stakes of stopping a seizure are literally life and death.
Which is exactly why doctors push medication adherence so hard, even when the daily side effects are miserable.
And what happens to the roughly 1/3 of patients who are completely drug-resistant, meaning no combination of these powerful chemicals stops their electrical storms?
For those patients, we are actually seeing a major resurgence in non-pharmacological interventions.
Like what?
The ketogenic diet, for example. It forces the brain to run on fats rather than glucose and actually predates most modern ASMs. It's highly effective for refractory cases.
Oh, I've heard of that.
We also rely heavily on surgical interventions in neuromodulation, like vagus nerve stimulation or VNS. When the chemical keys fail to turn the locks, we have to look for physical ways to alter the entire environment of the brain.
So what does this all mean? If we zoom out, we are looking at one of the most consequential, heavily utilized drug classes in all of medicine.
Absolutely. Epilepsy affects roughly 1 in 100 people worldwide.
Today we've learned that these drugs, these anti-seizure medications, do not actually cure the underlying disease. We learned that their discoveries were often the result of absurd luck, trying to sedate a noisy ward or using the wrong laboratory solvent.
Fear accidents.
We learned that matching the precise chemical mechanism to the specific seizure type is paramount, but that prescribing them in the real world is a high-wired tightrope walk between efficacy and brutal toxicity.
It is a remarkable life-saving field of science, but it is currently defined by its limits. And, if we connect everything we've discussed to the bigger picture, it raises an existential question for the future of neurology.
I love a good existential question. What is it?
We know from major clinical trials, like Nancy Temkin's landmark work with severe traumatic brain injury patients, that giving these drugs prophylactically right after a head injury doesn't stop epilepsy from developing months or years later.
So it only suppresses those early acute seizures. It doesn't stop the disease from taking root in the traumatized tissue.
Exactly. So the holy grail of neurology right now isn't just synthesizing yet another compound to suppress a seizure once it happens.
It's bigger than that.
It is cracking the biological code of epileptogenesis itself. I want you to imagine a future where a drug doesn't just calm the electrical storm once it starts, but actually stops the brain from ever building those storm clouds in the first place. That is the true next frontier.
Stopping the storm clouds before they even form. Going back to our X-ray metaphor from the very beginning, maybe one day we will finally have a medication that doesn't just hide the jagged white line, but actually heals the broken bone. Thank you for joining us on this deep dive. Stay curious, and we will see you next time.